Ms. Johnson will be joining us momentarily. We're also joined by Commissioner Patrick, Commissioner Messiah, and Commissioner Terry. So if we could start, we're going to go a little bit out of order to give Commissioner time to come up. Just to start with our medical examiner toxicology update.
Hello, thank y'all for having me back again so soon.
Absolutely, couldn't wait.
All right, is it up? All right, so I will be very, very brief. I know your agenda is full this afternoon, and I won't go through each and every statistic because you have them in front of you. But on our, we'll start with just our total report of cases, and this is everything that is reported to the office. As I informed you a couple of weeks ago, obviously not everyone that dies in the county is reported to our office, nor does everyone who is reported to the office require an exam. But we have about 2,300 cases reported last year. There was a significant bump in 2020 and 2021. If you all remember what was going on during those days, you will know why there was such a significant bump. But we haven't quite gotten back down to our pre-COVID numbers, so it has continued to remain pretty steady over the last several years. Specific to toxicology, we have quite a few tox cases. They make up a pretty large percentage of our total cases that we examine. That is because, again, even though cases are reported to us, they don't always require an exam, but toxicology cases generally do. The only time we would not bring those individuals in for an examination is if they have been hospitalized for some significant period of time. By that point, as Dr. Bolton could certainly attest, the exam that we would do would not give us very much information. It's really more about what was going on during their course of treatment, during their hospitalization, so we would not have to examine those individuals. We can sign them out after doing a medical record review. But we had a little over 200 toxicology-related deaths last year. And when you get into specific types of deaths, we'll give you a little bit of a timeline. I'm sure all of you are familiar with the timeline of the opioid crisis. It started back in the late 90s, actually right when I started my career in 1999. The first overdose case I remember distinctly working was due to OxyContin. And no one at the time in that office had ever heard of that drug. It was such a new drug and it was not being widely prescribed. And then we very, very quickly were seeing it all the time. It was the most prevalent drug between OxyContin and Xanax were the most prevalent drugs we were seeing at the state level at that point. That then led to a dramatic rise in heroin. Heroin made a very big comeback. We had not seen a large percentage of heroin cases statewide or nationwide in the country for many decades, not since the 60s type of thing, but we saw a dramatic comeback of heroin between 2010 and 2015, and then we have moved into our current wave of fentanyl, where fentanyl has become the drug of choice when it comes to opiate addiction. It is significantly stronger than heroin, 50 times stronger than heroin, 100 times stronger than morphine, which also makes it significantly more lethal. A very, very small amount of fentanyl from the street is very, very lethal. What we are now seeing in our current wave, and this has been going on for the last few years, even pre-COVID, is we're starting to see fentanyl mixed with stimulants. So we're starting to see a little bit of a methamphetamine come back, and cocaine has remained pretty high as people mix the stimulants with the fentanyl. So it's very similar to what we saw in the 80s. People called it speedballing when they would take cocaine and heroin together. Now they're doing fentanyl with cocaine or fentanyl with methamphetamine. The next slide shows you the drugs that actually contributed to the deaths. So again, we have a lot of cases where people have drugs in their system. A lot of people are prescribed therapeutic levels of these exact same drugs, and so we have to make that determination as to whether that is a lethal dose of that medication. Then we have to determine if they took too much of that medication intentionally, whether it be a suicide or this is an accidental overdose due to an addiction issue or mismanagement of medication in some way. And so you see we have a large number of drugs that we see regularly. This is not everything. These are just the high notes. And again, you can see oxycodone is now very, very low compared to fentanyl and other opiates that we see. And then, of course, methamphetamine and cocaine are still very, very high from year over year. When we look specifically at last year's data, of course, which is the most current data that we have, although we are starting to get our records together for the first half of this year. If you want the most up-to-date data, we could certainly supply that. But out of the 200 or so drug-related deaths, 114 are opiate-related as of last year. And 107 of those are fentanyl specific. And so it is by far the most common drug that we are seeing coming through the office. The pie chart breaks it down pretty easily. I know there was a lot of discussion regarding the cocaine and the fentanyl, but again, we're seeing this frequently as a mixture of the two, not just one or the other. And then I also broke it down just in case you wanted the information by age, race, and gender so that you can see how it's broken down among different demographics.
Yeah, I wanted to ask the chair, are we waiting to the end to ask questions, or can we?
No, if you have a question, you go ahead.
Yeah, I'll be very brief on that because I see that the percentage of cocaine and fentanyl is close.
Yeah, they're very similar.
Yeah, they're very similar. So, and these are the deaths.
Yes, ma'am.
Okay.
And that
Okay.
obviously doesn't take into consideration anyone who does not succumb to an overdose and who may survive long-term and need long-term treatment for addiction.
Right, okay. Okay.
So again, this is the demographic breakdown in case you wanted those demographics. And then next, I thought it might be helpful to look at the county via some heat maps. And so we went back as far as 2020 to give you a 5-year retrospective of heat maps and where we see the most drug overdoses. Again, in 2020, you can see it's pretty evenly spread out throughout the county. Again, we were dealing with a pandemic at that point, and that caused a lot of other societal issues. It wasn't just that everyone was scared of COVID, but they were at home, isolated, and it created a lot of other socioeconomic problems spanning many, many issues. As you move through 2022, you start to see a little bit of a decrease, and then all the way to our current heat map of 2024. We also broke it down specific to cocaine and fentanyl, since I know that those were the drugs that we were most interested in, and they're also the drugs that we see most frequently. And so we broke it down specific to those for the heat maps. And you can see there's quite a bit of overlap with those specific drugs, showing that they're used comorbid quite frequently.
With the heat maps, is this with respect to where the victim lived or where they were found, or what is that?
Yes, this is where the death would have occurred.
Okay.
Or where they were brought from. Had they, been taken in by EMS for treatment and then subsequently died at the hospital, this would have been where the incident originated.
Where the incident originated. Okay.
One other question.
Go ahead.
to me. And I want to go back to 7. And so it seems that black males, this is a breakdown of the demographic breakdown of drug type deaths.
Yes, ma'am.
So it seems like black males is the highest group
Yes.
of deaths.
Across all different substances.
Okay.
Yes. Now, when you look at
And-
population density and how the demographics break down for the county, that wouldn't be an unusual circumstance, depending, on where, if you look total drug deaths, across the entire nation, that demographic might not be the highest, but here in DeKalb it is.
Yeah, I understand that. And that's what we focus on is the DeKalb.
Of course.
Yeah. And black females would be next, and then white males and white females. Okay. Okay, that
Yes,
was...
overall, men overdose at a higher rate than women, and black males overdose at the highest rate.
Highest rate. Okay. Okay. And do you have a percentage of the black males and the white males? I see this chart.
I can get you the exact numbers, if you would prefer to
Yeah,
have
of
the
the
exact numbers.
percentage.
Absolutely, we can get that for you.
Okay.
I'll follow up with an email, and we'll get it to you ASAP.
On all of them, really, on this entire chart. the percentage of it.
Okay, we
Okay.
absolutely can get that for you.
Okay, now, I think you stopped on 10.
Yes. we just have heat maps.
Commissioner Terry has.
Just
Yes,
one
sir.
thing I wanted to note on that last slide. So can you just speak about sort of how y'all interpret the trends? Because I think what I'm seeing in this is that the black male demographic has gone up every year since 2020. The other demographics have either stopped or gone down. So talk about how you view the trends and what that means.
Yes, well, again, I think COVID, we were in such an odd time during the 2020, 2021. So if you see, there was a spike for white males in the 2020 to 2023, and then it's now dropped back down. I'm certainly not an addiction specialist. I think certainly in my line of work, you become very, very familiar with addiction, but I think that our COVID had a lot to do with, the various spikes here and there. We saw that in the heat maps. But as to why certain demographics have gone up and down over the years, I frankly can't speak to that. That's what we see. We report out on the numbers. Now, we are starting work with overdose fatality review. We are starting up an overdose fatality review board here in the county, and we will be a part of that. So I may be able, after we've had a chance to do a deep dive into a lot of these very specific cases, we may have a lot more information. There's a wealth of knowledge available after you do a fatality review on specific cases, and then you start to aggregate those individuals' personal data as to what was going on and what led them to addiction. But that's not something that's ever been done in the county before. So we would have to speak with someone either in addiction treatment specifically or potentially with public health. They may have a better insight into that information than I do.
Commissioner Davis Johnson.
Yeah, one follow-up on that, and that is, would you say that the population increases and the is with the black male, or is it with Latino, Asian community, or is it with the white community? Do you have anything to show where that population increase is coming
The
from?
specific population increases. No, I'm sure we can find that information.
Okay,
Because when we do
that
our
would
annual
be-
report, I will say
Yeah.
that this past year when we went to do our annual report, we get overarching data for the county from
Right.
Bureau of Vital Statistics, and we had difficulties getting our hands on 2024's data.
Okay.
As you know, Bureau of Vital Statistics is understaffed and underfunded, like many, many other government departments at the state level and federal level, local levels. And so we had difficulties getting our hands on very specific, even basic death data this year.
Okay.
Just what were the total number of people that died in DeKalb
So I
County
think
this
it'd
year.
be very interesting to know where that increase in population is coming from, because you can easily
Right, is the
assume
overdose
it.
rate commensurate with the
But,
increase in
yeah,
population?
because you have a lot of people moving to the cab, so it'll be interesting to find out where that population increase is coming from.
Yeah, we
So
will see
look
if we can lay
forward to
hands.
get that
Yeah.
information
We'll see
as
if we can
well.
lay hands on that. Again, we
Yeah.
got our information, in years past, we went to the Bureau of Vital Statistics to get it, and we had much more difficult time getting, we had to put an asterisk in our 2024 report that we had to use last year's total number of deaths for the county because it wasn't available to us
Okay,
this year.
thank you.
All right, so moving on.
Well, I also have a question about 7. So considering that we know a lot of, when it comes to the opioid epidemic, the street drugs, whomever ended up using street drugs started out probably on prescription. We also, from what I hear, cocaine and fentanyl traditionally have been more expensive than meth. So that prompts me to think about education and income differences between specifically black males, since they're the majority that have their increase in deaths from these. But do you have any data to communicate whether it is more educated folks versus those who may have less education or lower income that are dying from the fentanyl, meth, and cocaine overdoses?
Our office does not collect that as a matter
Okay.
of course during a death investigation. We don't have, education levels of our decedents. That is not information that we are typically privy to during an investigation. However, again, with overdose fatality review, that would certainly be a question that we would ask because you delve into a lot of factors in an individual's life to see, well, what leads us here, and then if interventions come along in various places and points, could that death have ultimately been prevented by those interventions? Then you take those interventions and you implement them in society, and you hopefully prevent the next round of deaths. So again, when overdose fatality review is up and running, I feel like we would get much better answers to those questions.
Okay, thank you.
questions.
Commissioner Johnson.
Yes, I have two quick questions. Do we have data on Hispanics, males and females?
We do. It's just such a small amount. We included the top categories.
Okay.
And the other component that we have, when you look at Hispanics is typically considered ethnicity, not a race. And so when we break down demographics, it can sometimes be difficult to tease that out from black and white. So
could
it
be
gets a little
in
bit
either
more
one of
difficult.
those.
Mhm.
Okay. And then you were talking about that overdose fatality review.
Mm-hmm.
Can you speak more on that and what the time frame is on that?
We actually, it's funny that you asked that. We just got an email today because we were asking, we got all of our agreements executed. We came before the board and got all of our paperwork signed, and Madam CEO's signature has been secured as well on our documents. So all of the legal documentation is in place for us to participate. We are hopeful that it starts this month. We're not sure exactly. We're not the host agency. We're just participating, but it's going to incorporate Department of Public Health, probation, DFACS. There's going to be a lot of different agencies involved. In order to have a robust fatality review, you need a lot of different agencies that have information about people and how they came to be where they are. So it's a huge undertaking.
Yeah, it sounds like it. And so I would assume then some type of report or something would come out of that review that we could then get access to at the end.
I would hope so as well. I've participated in child fatality review for many, many years, and each county's child fatality review reports are sent to the state office at the GBI, and then the state office cleanses that data and issues a report annually. Since overdose fatality review is not mandated by law, there is no legal guideline that you must issue reports. Surely that data is going to be collected, because if you do not collect the data and use it, then why do the work? But again, we're not the host agency, so we're leaving that to public health, who is sort of running the show for us. But I will be asking those exact same questions, because again, I've done child fatality review for so long that if it's going to be robust, you have to have all of those things in place.
Awesome. Thank you so much.
And on page 8 for 2022, there's only one area in the red, and it looks like it's about in the Doraville area. Everywhere else is in the green. Is there a correlation for that?
Yeah, I found that very odd as well. We just saw a decrease in deaths in 2022, and so when you spread them out, a lot of the areas got a little bit more purple, and so they get a little bit lighter. When you add them all up, they make that total, but they were a lot more spread out, and there weren't nearly as many deaths that year. It's just an odd. When you pick out 1 year, it's hard to make an assessment over 1 year's worth of data, but I also found that odd when I saw it. I was like, okay, whatever we were doing in 2022, maybe we could go back to that.
I also find it interesting that it's on the border to the next county.
Mm-hmm. Well, and we also occasionally, when we pull our data, you're constantly having to cleanse data, when you handle as much data as we do. And so we'll find, a dot pops up out of our county, and we're like, wait a minute, how did that happen? And it's usually because, an incident address has been reported incorrectly, or the person got transported to a hospital over the border into another county or something like that. So when you see the way death investigation is supposed to work in Georgia is wherever the incident occurred is the county that has jurisdiction over that death. But we get a lot of cases reported to us because a lot of the big hospitals are in our area. For example, they just finished Arthur M. Blank Children's Hospital last year, so lots of child deaths get reported to our office that are actually not our jurisdiction, and we have to tell the reporting staff, no, you need to call this county, that's where the incident occurred. So sometimes you see anomalies because of just the way reporting comes in.
Commissioner Patrick, you had something?
Just to note that there are some extended stay hotels in that area, and there is reports of sometimes housing units having double or triple families in there, and so that extra concentration of people may be a possible explanation for that.
Well, and you bring up an excellent point about when you look at societal factors and drug addiction, what overlap is there. It's the same with gun violence and poverty, for example. You know, those maps fit like hand in glove
Yep.
when you overlap them. And so you do see a lot of that where you start to see concentrated areas where people can live because they either have unstable housing or some other factor going on, or poverty is an issue, so they congregate in extended stays and things like that. So that's an excellent point.
Yep.
Thank you. If there are no more questions, you can go ahead.
All right, so now we're down to slide 11, I believe, by my count. And so again, this shows the national trend. So this moves us beyond DeKalb, but it shows how we compare to what is going on nationally. And you see again, the opioid crisis has continued, steadily increased, and then fentanyl with stimulants and without stimulants are now far above prescription drugs, which is what started this trend in the first place. Now, what are we doing to address the trends? We are constantly looking for new ways to modernize our data. How do we collect statistics? When you ask me questions, that puts another thought in my head. Or how can we collect that data? Or can we add another field? Yes, ma'am.
A question on the last slide. Would cocaine be identified on that last slide? So that would have been, as a stimulant.
Yes.
And so it would not necessarily have a category itself.
No, because this is specifically tracking the opioid epidemic. And so these are opioid deaths as they go up. And so you see the green wave was prescription opioids, which started the opioid epidemic in the mid-90s with Oxycontin, oxycodone. Then you get into wave 2, which was when everyone moved off of prescription medications to heroin, typically because it was easier and cheaper. That was when a crackdown started on a lot of what we would consider pill mills. And a lot of people overprescribing those prescription medications. And then you move into wave 3, which is where we saw fentanyl take over from heroin. And then wave 4 is what we are in now, where you're starting to see fentanyl mixed with stimulants, either methamphetamine or cocaine.
Okay, so if you go back to slide 7, is that, oh no, go back to slide 6. Cocaine and fentanyl was very similar. And so my question has always been tracking both to get an understanding of both. And so you got cocaine at 31.5 and fentanyl at 32.7. But then our concentration is on, let me see, that's the last one that you, on fentanyl. Yeah. So, yeah, without stimulants and stimulants. So we're not really tracking cocaine.
No, we are. If you look at the sidebar, the most common drug contributed to death breakdown, fentanyl and cocaine combined.
And that's on 6.
Fentanyl and cocaine combined contributed to 23 of the deaths. And then fentanyl only was in 18 of those cases, and cocaine only was in 16 cases.
Okay.
So again, they're neck and neck, but when you put them together, the lethality increases pretty dramatically.
Okay. Okay, thank you.
So when we go back to what are we doing as an office to address these? Well, I think one of the biggest things, and the thing I'm most excited
I'm
about.
sorry, are you going back to slide 12?
Yes,
I have
ma'am.
a question about 11.
Oh, okay.
On slide 11, where you've indicated heroin, no fentanyl, Is that not a combination at all, or were you clarifying that this is just the neat product?
There is certainly a subset of heroin and fentanyl together, but for the most part, in the second wave, you saw just heroin. That was the most common drug we were seeing at the time. And then when fentanyl hit the streets, people pretty much abandoned heroin and started using fentanyl almost exclusively.
Gotcha. Thank you.
And so we get into what we are doing to address these. Obviously, the thing I'm most excited about is the overdose fatality review. Because I've participated in child fatality review for so long, I really feel like this is long overdue. I'm actually someone who thinks we should be reviewing a lot of different types of deaths, suicide, a lot of different types of deaths that we could prevent if we were doing a robust fatality review of those subsets of deaths. But we also participate in Narcan training. Our office is providing real-time data to Claritel so that they can go out into specific neighborhoods and do community outreach. A member of our staff provides that data and then also participates in any Narcan trainings that they have, and we distribute Narcan when we can. We also do a lot of data modernization. Again, when you ask questions about specific data, it makes us think, well, look, maybe we can track that so that next time you have those questions, we'll know exactly, the answers and the numbers to that. We have a very robust system that we use for our case management. It was actually built and developed by a medical examiner, so it tracks so much of the data that we like to collect for not just our annual reports, but for our community outreach. We have a grant project currently with an organization called ACOR, where we are developing a public-facing dashboard. And their requirement for building the dashboard is that our overdose data be public-facing, but then we get to choose the other categories of cases that we would like to put on that dashboard, and that can change at any time. So we can track our own trends and say, okay, if we're having more car accidents or, children not in car seats or pedestrians being struck, we can put that information public facing so that the public can see the work that we are doing, and it can help guide our other community interventions and prevention efforts. So we are passionate about using the data that we have. For too long as a group, medical examiners and coroners, we've known about all of these issues, but the data dies with us, if you'll pardon the pun, because we don't actually do anything with it. And so this office is quite innovative in that regard, in that they have been, for years now, looking at ways to modernize our data, collect more information so that we can then do something with that information and help try to prevent some of these deaths from occurring. And then these are some of the grant projects that we talked about. You all have seen these before. This is just a recap because you've approved them all. And so you've seen this information many, many times before. You don't need me to go through it and read it to you again. But we talk about all of the different projects we do. This is where that money goes and what we do with it. Down at the bottom, since we are talking about opioid cases specifically in our talks presentation, I talk about the opioid settlement money and what we could potentially do with opioid settlement money should our office be awarded any of those funds. We could continue our ACOR database. Our grant will end. We can't keep it going forever, but it is about $15,000 to maintain that database year over year, so that potentially opioid settlement money could maintain that public-facing database once our grant ends. We could utilize it for more intensive toxicology testing. Tox panels cost a lot of money. Basic tox panels are relatively cheap, but if you really want the expanded tox panel so that you catch some of the more what we would consider designer drugs or drugs that don't show up on your basic screen, we have to pay for that extended panel, and it's very, very expensive. If we try to use the state's toxicology lab, we could do that, but the backlog is very, very high, and it would take many, many months to get those results. So that not only would delay the death investigation for our families, but then would also delay our statistics.
And about how much is the cost?
We spend, I want to say, I have to check with my staff, but I think we spend somewhere about $75,000, $85,000 a year on toxicology. So it's quite pricey for the cases that we send out. We use.
But if you did it, I'm sorry, but if you did it in-house, how much would it cost?
Well, we do not have a toxicology lab in-house.
Oh, okay.
Yeah, we do not have that capability.
Okay.
I mean, if we were to built one. I'm sure Dr. Bolton could help us with that, and we could build an in-house toxicology lab. I'm certainly open to that idea. But to get a full accredited toxicology lab would be quite pricey, I'm sure. And again, we could use the Bureau, but they are backlogged because not only do they do their own death investigations toxicology for the state ME's office, but they're also responsible for many other medical examiners' offices in the state, as well as toxicology that does not relate to a death investigation. So blood alcohol testing for Georgia State Patrol on DUI stops, for example. So they have a massive backlog that they have to handle.
So I evidently missed something. I jumped from A to C. I missed B. And so what would your alternative be other than the state?
We use a private lab. It's called National Medical Services.
Okay.
Yes, and that's one of the reasons our
And that's
turnaround.
the $75,000.
Yes, and that's one of the reasons our turnaround is so good, because it is a private lab, and it is expensive. They do fantastic work. I'm certainly not complaining about the price that we pay, but and they also turn our tox around very quickly. Usually we have tox results within 2 weeks.
Now, what about the state? Would we pay them or?
No.
Okay.
And if we have a case where we do not suspect that tox is a factor, but we still feel like for a comprehensive investigation we need that done, we will send that to the state. But if we think tox is the cause of death, we do not want to have to wait months to get that toxicology screen back to do a death certificate for that family. So we don't want to delay, and that's one of the reasons we use a private lab so frequently. And so that's just one of the many ways that we could use opioid abatement funds. We could always hire more staff. There's always the possibility there. We have the Morehouse Fellowship Program that we just got up and running, and we have our first fellows starting next year. When we look at salaries and abatement, that's not typically seen outside of an organization like Claritel, where they would need more mental health counselors, for example. That's not typically seen as a use for abatement funds, but in our instance, we believe it's very warranted because of the way our caseloads have gone up over the years specific to drug-related deaths. So having more doctors, more investigators, and more staff help cover those increases that we have seen because of the opioid crisis that has been going on the last 20 years. So there are a lot of different ways.
Last question. And so you have no figure as to what you would want from the settlement. You have a question.
Oh, I have figures.
But you didn't put it here.
No, I did not.
So,
I did not. But because it would be completely up to what we would be asking for, what we would feel was reasonable, whether we wanted, the fellowship salary, for example, the fellowship salary is $150,000
So
annually.
what would you be asking from the settlement?
The fellowship salary, our tox testing, so that would be $150,000 plus $85,000. The keeping our ACOR database going would be another $15,000 a year. If we were to hire another investigator, that would be somewhere in the neighborhood of the $65,000 to $70,000
Well, I don't have a
range.
calculator with me.
300,000.
Yeah, we're
About
closing in on
300,000.
300, but we have a lot of ideas that we could use, and also as part of our ACOR grant, a consultant was provided to us specifically to help determine what is the best use of abatement trust funds and opioid settlement funds. And it can be used by anyone in the county. They're not specific to the ME's office. And so if you wanted us to put in contact with her, we certainly could. And you could look at other ways that money can be delivered to the community.
Well, I had another commissioner to ask me,
We should have had this presentation.
are your facilities
weeks
modern enough?
In my opinion, no. We would love to upgrade our facilities. Our building is closing in on 30 years, which is not necessarily very old in the grand scheme of buildings, but when you look at a medical facility that requires the specialized equipment that we use, it needs a significant upgrade, and we are also completely out of office space. We are crammed in there. Dr. Bolton visited us recently, as did Commissioner Patrick, and we have made use of every little bit of space that we can find. We have our public education specialist literally in a converted closet, and she's done wonders with the space. She's quite creative. But if we were to have an additional fellow, Morehouse has agreed to allow us to have 2. But again, that would require another $150,000 in salaries, so $300,000 for salaries for the fellows plus office space. So we would love to expand our education program as well as all of the other services that we provide, but a lot of that is contingent on our facility.
Commissioner Messiah.
Thank you, Madam Chair. And so in terms of the cost for, and I'm going to piggyback a little bit because I have some questions related to the cost as to get some of these things done, piggyback a little bit on Commissioner Davis Johnson. So as it relates to the toxicology lab, I mean, because for a county of our size and, you know, considering the significance in terms of the number of lab costs that are going to private entities and the need for them, to build out a toxicology lab and maybe save some funds long-term versus using a private lab. What is the cost of that generally? You have some idea?
I would be guessing,
Okay.
but I would expect it to be in the millions.
Okay.
To build a toxicology lab and then to have the type of equipment that you need. The equipment itself is very, you know, mass spectrometers run hundreds of thousands of dollars in and of themselves, and then they obviously have to be serviced and calibrated with regularity. And then the staff for that, because you have to have accredited, well-trained toxicologists to run those machines. And so it would cost. It would be a very, very large amount. It was not something, even when we think about long-term what we would like for our office and services that we would like to include as we move forward, you know, we've thought about, and this is a random example, but there's a new machine that is, the acronym is called ANDI, and you're able to do DNA testing. And we could get one of those, and we could start building a DNA database, for example, of all of our unidentifieds. And then we
Wow.
could actually do it for the entire metro Atlanta area. We could get all the other ME's offices to send them. That is a reasonable and feasible thing that we think we can do.
Okay.
Toxicology would be prohibitively expensive, and at least from where I sit, that would be much more a decision for you all, and we can certainly do the research on how much a tox lab would cost, if that's something you're interested in.
It is, and in terms of, you said the name of the equipment was Andy?
Oh, the DNA machine is
Correct.
called ANDE, A-N-D-E.
Okay.
That's we recently priced that out. A used ANDE machine is a few $100,000, and then you have to have a service contract that is about the same amount as the piece of equipment. And so we've priced that out. We've actually looked at getting that machine as part of the grant under our cold case task force with the DA's office, where we've been working on our
Right.
unidentifieds, but we're running out of money in that grant, and we're not sure it will be renewed. So we're not sure if we'll be able to get it. We don't think we're going to be able to get it this cycle.
Okay. And it'd be helpful to know that as well. I mean, just so we can keep it as food for thought moving forward. So when we are having and awarding some settlement funds and going through the process, to have an idea of other entities within DeKalb County that actually, departments within DeKalb County that have this specific need would be very helpful. All right, and then just briefly looking at 12, and I'm looking at, you know, what DCMEO is doing to address the trends, and particularly it speaks to how and what each of the particular entities are doing. For instance, when it comes to DeKalb Public Health, you seem very excited about that overdose fatality review. So that's a way specifically that you intend to partner with them, and that's going to be, you know, addressing substance abuse. The Narcocan, that's mentioned in terms of what the staff does and hotlines. DPH, that's mentioned in terms of pursuing medical records, prescriptions. So as it relates to, absolutely, I am Claritel. It just says that it is addressing substance abuse and mental health, but it's not saying how it's addressing substance abuse. So I'd like to understand how Claritel particularly is partnering with you guys to address substance abuse. What things particularly are they doing?
We provide real-time data to them when overdoses are happening in the community so that they can target specific areas of the county for outreach and Narcan training. So that's the most specific thing that we do with them. Anytime they need data and information, we obviously can provide it. But the most specific thing we do with Claritel is we do either Narcan training with them, or we are providing real-time data so that they can go out into the communities where the overdoses have occurred, and then they can help in that specific community with getting potential treatment to individuals in that area, giving out Narcan, doing education outreach.
Okay, so it's, mainly just providing them with the information that's necessary.
Yes.
Okay. All right, well, that's what I needed. Thank you so much, Madam Chair. Yield back to you.
Okay, I do have one or two questions. I did want to ask how the impact of the reorganization at CDC, the layoffs, if they've impacted the funding that you guys normally receive. Do you anticipate not getting those funds in the future?
Well, thus far, no, because the funding that we have received specific from CDC is coming from the CDC Foundation, the
gotcha.
private entity, not the CDC itself. So we have been very fortunate. But as the belt tightens across the board, we certainly see those monies being redirected, and we are concerned about some of our grant funding moving forward. Thus far, none of our grant projects, thankfully, have been impacted.
Okay. And then I also wanted to ask, when it comes to, drugs being smuggled into the jail, and I don't know if you guys see overdoses, opioid overdoses from the jail, but how do you heat map those if and when you get them?
They would show up as that address, the jail.
Okay.
But I can tell you, at least during my tenure, which has been relatively short, just since November, there has only been one death at the jail, and it was not drug-related. It was a natural disease process.
Okay, gotcha. And then, you know what? I don't know if this is actually a thing, but considering that we seem to have support for a toxicology lab, I'm thinking as opposed to initiating a full capacity lab immediately because you have that third party support, maybe, I guess, pilot or slowly evolving into that capacity by starting maybe with one GCMS or just small scale to take on some of those cases initially until we can come up with a strategy to build out long term. So if we could start to have those conversations sooner rather than later, since the support is there, I would be happy to do that.
I would definitely need your expertise for that. You're wading into a section of chemistry that I haven't studied since 10th grade. So.
Wonderful. If there are, did we go through the last slide?
I believe we're close.
Okay.
Just these are our data sharing partners. We automatically, we do as much automated as we possibly can, obviously, to cut down on the hours that our staff have to spend, doing these data pulls and things like that for different organizations. And so we have agreements with all of these individuals, and then the ones that are highlighted in red are automatic, so that we can do those things very, very quickly and easily, and not use a lot of staff hours to share that data. And then this just shows how our data sharing program moves through the system. We collect the initial data when it comes in from the deceased. It goes through Department of Public Health, then through the CDC, gets sent to Claritel at a different level. When we work with Claritel on the community intervention front, that's a separate piece than the overall data that we send that goes into Claritel on the back end through the CDC, which then contributes to all of the other overdose prevention efforts that are going on in the state and the county. And then, of course, policy, long-term, is what you're working for. And that's the end of it. So thank you very much for having me.
Absolutely. Are there any other questions from Commissioner Patrick? Go ahead.
Just a quick comment. First of all, Director, thank you for the tour. Very
Glad to have
knowledgeable,
you.
very professional. I had my limits. I'm sorry.
That's
I had my
okay. It's
limits.
not everyone's cup of tea.
It is tough. We recently took a tour of Grady, and I forget the program that they were discussing, but it was basically an epidemiological approach to crime prevention, and I suspect the medical examiner's office would have some kind of input on that.
Was it Cardiff?
Cardiff, that was
Yes.
it. It would be well worth us looking into Cardiff and maybe trying to revitalize that and make sure that it's functional, because I think that I hate to say it, if we know how people are dying, we know how to keep them alive as well.
Right.
And that might be a right approach to that, so.
And we do have good partnerships with Grady in place. They do a lot of our lab work. For example, when we need blood cultures and other types of testing, Grady supports us in that. So we do have connections there, and we can absolutely make that happen if we need to.
Perfect. Thank you, Madam Chair. Thank you, Director.
Awesome. Any last questions or follow-ups? No, wonderful. Thank you for joining us.
Thank you so much for having me. I feel like I need to come back in another 2 weeks and talk to you guys again. It'll just be a regular thing. So have a great afternoon.
You too. Thank you. All right. Okay. We have another presentation and then probably only just enough time for maybe 1 or 2 agenda items. So if we can go ahead with the wellness program presentation.
Hi, good afternoon. It's nice to see you all. Those who are new, welcome to DeKalb. Glad to have you here. I'm happy to have this opportunity to give you a little overview of wellness. We have a pretty robust program here at DeKalb with employee wellness, and I think you've got some sheets in front of you that have a list of the different activities and the priorities with wellness, but I want to kick off with letting you know that the Atlanta Business Chronicle has selected us as one of the healthiest employers. We are on the list. We don't know what our actual ranking will be until August 28th, but I look forward to competing with Emory and Gwinnett and MARTA. We'll see where we land. I think we've got a program that stands a good chance of getting a great ranking. So that's the first thing I want to tell you about the program. The application had to be completed with all kinds of information about our reporting, about all kinds of health benefit information, worked with Gallagher, our consulting company. It also had to do with what kind of leave we offer parents as well as for taking care of parents, things like that. So HR also worked with me on that application. So that's a pretty exciting thing to kick off this new benefits coverage year that we've started. The DeKalb Employee Health Center is one of the biggest programs that we have. And if you are an Anthem employee, active, or a pre-65 retiree, those members and their insured family members are eligible to use the DeKalb Employee Health Center. We've had it open a little more than a year and a half now. We have a nurse practitioner, Diane, who has been a great fit for our population. Everyone loves her. She has a Net Promoter Score. I think it's averaged over the last 12 months of a 95. To give you a comparison, I think Chick-fil-A is a 58. So Diane or a chicken sandwich, people love Diane. That's to give you an idea about just how terrific she is. I just got an email right before I came here about they had a great experience at the health center. So that's a really big deal that we have that. They'll be helping give out flu shots this year along with our partners with Kaiser. We have the Kaiser program that we have $250 incentives that employees get that are Kaiser members or spouses that are on their program. That $250 is for them to engage with health, kind of the same way they're doing with the health center. So that's a really important partnership that we have. So we'll be doing flu shots coming in October, and we have a yoga class that we're doing with Kaiser. We'll have the Kaiser 5K coming up really soon. So we have a lot of really special events coming up with both our healthcare partners. Another really big deal that we have at DeKalb that not many other places have is we have an exceptional tobacco cessation program. It's called Pivot Tobacco Cessation. It's a very respectful program. I find that we tend to look at tobacco users, we think about the nasty habit that they have, and we don't think about the struggles and the fact that many of them were handed cigarettes when they were 12 years old. And this is not a habit easy to kick. And Pivot is free for them. It is completely private. It's not connected to any of the benefits programs, so they don't have to be insured. It's for their household, it's for their families, but it has a detector, and it's one of the few of its kind. So they have this, and they exhale into it. It's gamified so that the carbon monoxide a tobacco, like a cigarette smoker or a vapor, would exhale will show up as red, green, or yellow, and it's gamified. You don't even have to think about what those numbers mean. But it comes with an app. it comes with coaching, it comes with nicotine replacement products. So it's a really fantastic program. We have high utilization, somewhat predictable. We get 55 new people at the December-January time period. That's when people typically want to kick the habit of tobacco. Throughout the rest of the year, February through November, we'll have up to 3 people per month that sign on to use the program. And that's typically from a new employee orientation, or if I'm out at an event where I'm able to talk to people. Tobacco users are sometimes a little bit on the fringes, so we have to find them. But this has been very well received by most all of them. So that's a very big deal. I was going to go in and tell you about some of the upcoming events we've got. Does anyone have any questions for me at this point? Can we just keep?
I do have a question
ahead.
about the Pivot Tobacco Cessation Program. Since February through November, we have fewer than 5 enrollees. Do we have to pay into this Pivot program?
Are you thinking about monthly cost?
Yes.
We actually have a flat annual cost with them.
Okay.
And we're just doing reviews over that. It's about $470 a person if we were to pay by the person. When we pay the flat fee, this enables people, if they lose this, and this little device here is almost a security blanket. And I've gotten feedback from employees, I've gotten family member, because we'll have a mother who worked in Watershed was talking about her son who worked in a different department that he was using it. This is very important. If we had a per person user, they would have to pay for getting a replacement. And if you think about who a lot of our tobacco users are, they're doing hard outdoor labor, they're gonna lose it. They're just gonna lose it. It's gonna get broken, it's gonna get crushed, it's gonna get lost in the trash. So replacement's a really big deal for this. So right now, we are almost at the amount that we're paying per year. It's incredible utilization. I discussed it with our consultants, and we all agreed paying and one annual cost is great. The hope is to always get more people to use it, but the other problem is that the recurrence of picking up tobacco again is very high. So oftentimes, they may have to get into the program a second year. Mm-hmm. So this can help them. So reduction is actually a major health benefit as well.
Okay.
So, yeah, so the average is a good number for the year.
Do you know what that number is offhand?
How many people are using it per year?
Yeah, versus how much we're
Well,
spending.
I think the latest report, we had 226
Okay.
who were using it. But it's the new enrollees that we watch the pattern on. And we've only been using the program, it's not quite 2 years now.
Okay, it's still
Yeah.
pretty new. So folks
It's relatively
probably not
new.
even aware.
The hardest part is getting to the people to know that the program is there. That's the hardest part. They're not going to be reading my emails. There's only one of me. So it's a matter of me capturing them at the moment. So part of the promotion, too, is go ahead and order it, have it on hand. I talked to them about, just think about those mornings you wake up and you're ready to make a change for something, but you don't have it available. That's a big part of their promotion, too. Just go ahead and order it, have it on hand, so that if you know at that birthday that you want to make a change, or the beginning of the fall, or Christmas, whenever you want to do it, you'll have it available. So we do promote it from that direction as well.
Okay. Were there any other questions from commissioners? No. Oh, Commissioner Terry.
Yes, I just wanted to make one comment that you were amazing.
Oh, thank
Because
you.
you just said you're the one wellness person for 6,000 employees, and we've been selected one of the healthiest employers. Imagine if we had 2 of you, or if you had a support team, and it's great to get an accolade like that. That's great. The money that we could be saving by small investments in wellness is into the millions. All right, prevention, what is an ounce of prevention, pound of cure? And I've seen this. I mean, my degree is in food science and nutrition. I remember very vividly in college at the University of Florida, we actually worked with the city of Gainesville. The city of Gainesville said, we're going to install a gym, a nutritionist, a wellness person. They invested in a team for a kind of a small city. They saw their health insurance premiums not go up and up and up like we've seen every single year in DeKalb County. They saw them bend the cost curve. So this is millions of dollars we could be saving that, I mean, clearly we have other priorities out there. So if we can find small investments in your program, imagine how many more dollars we could save.
Well, I
you don't have to
appreciate
answer but that's my thought.
Thank you. I appreciate that. Well, and to give you an idea of the upcoming things that we have, a big part of wellness is engagement. You have to connect people, and I joke that in order to talk to someone about diabetes, oftentimes you have to hand them a hot dog. You have to do something to draw them in. There has to be a hook. So I do work, and I think that was originally what the interest was of me coming in, is talking about the discount program. And there is no formal discount program. It's something I started doing in order to get attention to the program. A way to get people to pay attention is you get a Falcons ticket link, you get a Hawks ticket link, you get an Atlanta United ticket link. Those are really popular programs, and the partnerships with the pro teams as well as some of the semi-pro teams in town have been really fantastic. To give you, I love to tell the story of a police officer who has a 16-year-old son. She wanted to take her son to a Hawks game. An important part of that was she wants to spend her dollars the right way, but she wants to have an exceptional experience. And she was able to reach out to our contact with the Hawks. They helped her find the right ticket. They helped her navigate. Here's how parking's going to go. Here's your concession dollars for this. Here's the best price ticket, in that location. And they helped her. So we've had a number of stories like that. So that's a very helpful piece. But I don't have the bandwidth to do a big employee discount program, but where it falls in naturally and where I can get something that's recurring that they approach me, that's where I focus on the discounts. Gym discounts, that's a big one. Oftentimes gyms will reach out and say, we'd like to offer your group a discount, and I'll advertise for them. I'll let people know that that's one of the choices that they have. But we have a lot of big events coming up. We're starting our compassion class. I think we are the only county that I know of that offers a compassion course. And the compassion class is a 9-week small group course where, unlike most employee development things, it's not about how I deal with you, it's how I deal with me first. And the course, most people in feedback say they think it should be a required course. It makes a huge impact on their lives. To give you the idea of people coming out of their job and sitting for 2 hours quietly to reflect on things and to learn how to engage with other people is a pretty magical thing to watch happen in a group. So very proud of that one. We are having, I think I have the 4th cohort there. It's actually our 3rd cohort that's getting started this time coming up. We have the Healthy Wage Step Challenge. There is a commissioner and I think other staff members who have done the Healthy Wage Step Challenge. It is no joke, and it is one of our most popular things. It's very hard. People do it for 60 days. It's a focus. They have to increase their steps by 25%. But again, feedback is people find it somewhat life-changing. They love dedicating themselves to something, and they love what they get from putting in that effort. So it's a very big deal. We usually have about anywhere from 80 to 90 participants in that. And last time we were able to use some wellness dollars. Everyone got a pair of new shoes from Big Peach. Tennis shoes. It was a big deal. People loved it. That was really exciting. We are doing a collaboration with Kaiser Permanente and Parks to do yoga in the park in the Saturdays in September and October. That'll be fun. That will be for both employees, and they can bring their friends. It'll be outdoor yoga on Saturday mornings. Mobile mammograms will come. It's the second one that we'll have this year. That's a big deal to give that opportunity. When we do not have enough, and it's based on eligibility with health records, if we do not have enough participants, I will reach out to commissioners to let you know. Please advertise it to your communities. They're welcome to use it. And that's a dual purpose. It's great for us to provide it for the community, but it's also important to have a few on-site events per year for the employees. Seeing the bus itself is a major advertisement. We have blood drives. That's an important partnership with Fire and Chief Fulham. We're able to use the building at West Exchange to have 6 blood drives per year, and then people get blood time. They get 4 hours blood time when they donate blood, which is a partnership that's been in place since actual CEO Maloof with the Red Cross. Nationwide, we'll have an Investing in Retirement event. Those are popular lunch and learns. We'll have the Kaiser 5K, where we've already got 41 people signed up for that, and I've really barely advertised for that, so that will have a big turnout this year. And in October, we will start the annual Shotapalooza. We will have flu shots at a minimum of 3 locations, but probably a couple of other locations around DeKalb. So the attempt is, even though there's one of me, I try to do little things that apply to different people. So it's the hope that maybe you're focused on physical, maybe you're focused on emotional, maybe you're focused on social. It's the idea of trying to find something that fits with you so that when you're ready to go on to the next thing, you have a resource and you know where to go to ask the question. And I'm able to send you then to our benefits. Maybe it's through Anthem or maybe it is through Kaiser. The other thing is that sometimes even if they aren't on our benefits plan, maybe they'll end up there, or they'll certainly be on retirement benefits plans with us. But the important thing is for people to know what questions to ask, and that's something I've learned over the last decade is if you know what questions to ask your own insurance company, you'll know what programs might exist that you might not be seeing otherwise. So that's an important piece. And then
and I think,
I'm sorry, go ahead.
Terry, did you have a question?
Yeah, just real quick on the healthy wage step challenge.
Yes.
So I think that's great. In fact, actually, I remember when we started it a couple of years ago, I challenged COO Williams to the step challenge, and now he's running half marathons. So clearly it's working
That's
for
happening.
some folks. One thing I wanted to maybe give a little feedback on, because when I did it the first time, I was like around 8,000 steps.
Yeah.
The challenge got me above 10,000.
Yeah.
But then the next time, it like made me have to do like 14,000
Yeah,
steps, and it
yeah.
became almost too much to do. So is there a way, as like you, let's say you're a first entry and you kind of get yourself up, is there like a threshold where it doesn't like force you to do 20,000 steps and it becomes unrealistic? And then for me, it was unmotivating because I was like, I'll never get there.
So so before anyone pays, and they put their own money in to do this,
Yes.
and you get your money back if you meet the challenge, and you get a little bit extra back. I think this last time we have a really high success rate, so I think we got an extra $1.50 back or something like that. This last time there was not much extra, but you can see what your goal is before you pay. That's one thing. And listen, I feel for you. Mine, I've already gotten mine pinned down at 17,000. So it's going to be a tough 60 days for me, but that's actually lower than the 18 I've had in the past. So, it is based on what you're already doing, and so I think that's part of the satisfaction of it, though, for people. It's that you're given this number and you have a problem to solve. And oftentimes, a lot of the coaching I do within this is people come to me and say, "So I'm making a trip. What am I going to do?" And I'm like, "Walk the airport." Don't, whatever you do, ride the train, walk the airport, and bank your steps. So it causes you to focus on the exercise. So people are thrilled when they're done because they're like, I don't have to just be solely focused on this part of my life. But there's something satisfying to solely focus on one thing in your life. And I think that that's what people really like about it. I had a lot of people who said, I will never do this again, and they're the first ones to sign up. It never fails. And people said that, talking about how much weight they'll lose in it. Some people say, I made it through Thanksgiving without gaining weight this year. It was just, so the feedback is pretty phenomenal, but I don't disagree with you. It's a hard challenge. There's no way around it.
I've been
It's hard.
slacking recently, so I might actually be back down below.
Well,
So
I do it.
I'm going to sign up.
Listen,
on
I was
September
happy
5th.
mine was a little lower than it's been. I'm really happy about it.
I wanted to mention you have a lot of amazing things on here, and I usually try to review the emails that you send out. In the spirit of what our friends at M&J said about our departments working more like partners in order to meet the common goal of the county, I think it would be a little easier to follow some of the things that you share if maybe, and I'm just going to throw something out there, the communications department helped with putting together a template that was more user-friendly and organized things to make it easier to follow, so that the things that the employees are interested in are easier to find in the communications, and then we can go and attach ourselves and begin to implement some of those things. Just a suggestion, because I'm not sure how you do it, and I know you're one individual, but I don't want us to lose all of the work that you've put in simply because we have a little bit of difficulty navigating the abundance of information that you provide.
I think I appreciate that, and it has been suggested that I use a template. It's funny, when I've started to go into using a template, it is literally, it's bandwidth. This is me doing all these, and so I get the information out there, and so that's why this has been the easiest year for me to put together this fall, because most of these events are repeat events. The wellness dollars have, the way the Anthem contract has been negotiated now, I have wellness dollars that I can use a little differently, and so I'm able to very quickly put these things into place. So most people are reaching out to me before I send any of this out. I have them sending me emails saying, when is the next step challenge? We know we're coming up on a new one. When is the next compassion class? When is the next blood drive? But an important thing to know is that we have a microsite for risk management. I have that with my signature on my email, and it is yourdekabbenefits.com. And it's the first thing I tell people to go to in new employee orientation. We have a calendar on there with all the events. You can get to all the benefits information. You get EAP information, the Pivot Tobacco program. You'll find mobile mammograms. Everything is on there that is any event coming up. So the email is really the trigger. So the times I don't let people know, and it's like this sometimes, to let people know, for instance, when we're having one of the Kaiser Permanente webinars, I had 15 emails that came in and said, you didn't send the reminder. Well, my system wouldn't go quickly enough, and I couldn't get the reminder email out. So it's kind of a, you know, I hear you. I completely understand. I would love for it to be more polished, and it would be great to have the time to be able to polish things a little more, but I have found that the engagement is still there, and people are aware of it. Not everybody's going to do everything, and I think if I tried to tie that to my ego, it's what it would happen. I can't do that, but I'm try to be available for what anybody needs. So I agree with you. There is something to the polishing, but you do sometimes lose things to the polishing. So, you know, I'd love to have that opportunity if there was assistance on that front.
Absolutely.
That would be great.
So, oh no, go ahead.
Oh, no, I think Commissioner Patrick?
Did you have something? I didn't see you. I'm sorry.
I was going to ask Commissioner Terry, how many steps does he get in? And if you're up for a challenge, sir, I'm up for a challenge with you.
Uh-oh.
Publicly.
Uh-oh.
Publicly.
Only if Zach's in it.
What'd you
Commissioner
do?
Messiah.
Hey, Zach's got the same hills I have to deal with, so.
Knees. Commissioner Messiah.
Thank you, Madam Chair. So as it relates to our CB 360, and I know there are some things that were listed in terms of in the benefit section of what have been mentioned, just to, you know, piggyback a little bit more on what Commissioner Bolton had been sharing in terms of ensuring that that communication is put out there a bit more so that there is more engagement, involvement, utilization, and then we're capturing that number one, because I don't know, we have Kaiser and MARTA, and so hopefully we'll, you know, kick tail on that extra large area, but just the utilization of CB 360, how much have you been utilizing that, and do you see the potential to utilize it more in order to make known just some of the benefits that are being offered through the wellness?
So wellness is not connected on CB 360 at all.
Oh, it's not?
No.
Okay. Because I
No.
thought the smoking piece of it, but maybe it should in terms of the, me too, because I thought, I remember seeing something as well.
You may have seen maybe when you went through open enrollment.
In
On
one of your emails.
Are you? It's definitely not CB 360. I'm on the micro. We have a microsite, like I said, the Your DeKalb benefits for risk management. But the only thing that CB 360 that I'm connected with is that I promote. I promote for other groups. They come to me so that the communication gets out, because it's just I'm their newsletter, basically, is what it comes down to. And so for safety. Safety does some of their classes. Those are all listed on CB 360.
Okay.
When we do the nationwide, that's actually the safety manager, Monica Allen. She helps me. She sets up the class on CB 360, and I have that. They sign up there. But that's a favor she does for me when we're doing the financial education, is how it is. But no, it's not. I think you can get to the benefits guide from there, but that's it.
So maybe the utilization, you know, and it seems like it's some benefit when you have some assistance to be able to, and I know it's all based on capacity to get it on there if it's related to education, but to the extent there can be more of a utilization and implementation there, then maybe we'll get more utilization out of employees. Just a suggestion, and think, you know, thoughts around how that might be able to be accomplished in working with, you know, COO and the rest of the administration on, getting that achieved.
I think that there is a wellness section on CV360, but it's not activated, is what I'm told.
Okay, so maybe that's what we do. All right. Thank you. I yield back to you, Madam Chair. Thank you.
Okay, no other questions. You can, if we can go through the rest of this, I don't want to rush you, but a little bit quicker.
Yeah, it's just, there's just a few highlights. Wellness reimbursements, big deal when people get to choose their gym and they input the frequency of how often they attend and payment records for a year. They get a reimbursement back, 50% of what they've paid, up to $300. That's a big deal. Learning to swim, I think we're probably one of the only groups that will help and guide people to learn to swim. And that's only for the adult employee that is eligible for that, but give them a little guidance and they can get a little money back towards learning to swim. It's a big deal for them. We have numerous gyms around the county. The 1950 West Exchange Gym is the public safety gym. It's opened up to anyone in public safety and anyone in those two buildings. It's a large gym. It's a very well-liked gym. But in the last 2 years, we've managed to open one here on the 3rd floor at Sam Street. We've opened the Pocket Gym on Swanton Way. East Collections Lot has a gym out there. And then we have the Peak Performance Fleet Management Gym at Fleet Management. So all of those have been well-loved, and we hope to get some more in different places as well. As I've mentioned, the blood drives are a big deal. We have 4 5Ks every year. We do the Love Run that's kicked off with the DA's office in February. We have the Aware 5K. That's the Wildlife Rescue Group. Kaiser 5K, and typically Parks puts on a race. And then the other part is just different collaborations that are done, and that would be EAP promotions. HR manages the EAP contract, but I do promotions and host a quarterly info session for people to ask questions about EAP. Delta Community Credit Union does a lot of financial education, and as well we have hostile event workshops. We've gotten that into multiple departments. The Board of Commissioners staff, voter registration, as well as the UCO water billing group has done the hostile event. Anybody who's dealt with the public, that's a pretty big deal for them to do that. And then the only other thing would be our parks yoga. That's going to be a big deal, and walks and 5K. That is it.
So I do want to iterate a couple of things. I would love to see how we can support you in your role, understanding that you're the only person doing that, especially the use of technology to work smarter so you don't have to put in so much effort. And that could be a host of different things. So I don't want to lose that part of the conversation if we can make note of that to central staff, the use of technology to help support you in your role. And also to reiterate to the commissioners, one of the reasons that I wanted to have this conversation is because, and you guys have heard me joke about kudos points. I was joking, but I was serious, because I think it's very important for us to commend each other, both privately and publicly, on the extra effort we put forth in helping each other. Because again, as I mentioned a little bit ago, our friends at M&J said we need to be more of partners to each other and centralize efforts to move forward the county's vision, mission, and initiatives. And you indicated that you had sort of a discount program, and what I heard you say is that healthy people are happy people, and they are compassionate people. And so the more compassionate that we are, the more that we help and support each other. And so in that likeness, I think it's important to do kudos. And to give you an example of what I would like to see, but of course that can be a discussion later, is there be some sort of dashboard where we can comment to say, hey, COO Williams came and helped put 500 stickers on my Bumba socks last week, and I want to say thank you for helping us to do that. Not only put the comment for others to tell him thank you and give him kudos as well, but if we add points, and where these points could be collected to maybe later do the tickets to the basketball games or whatever relationships we have, buy a new stapler for our desk using the point system as opposed to putting dollars or something in somebody's pocket, but to help increase morale, bring us together more, which is in line with what the assessment was this morning. And just improve outcomes of service delivery for the community overall simply by applying a system of kudos. So just, I would hope that we could house that with you, but understanding you don't have the capacity in the discussion with using technology to support you in your current capacity, but also how we could potentially in the future incorporate that as well. It may be another staffer, but that's a discussion I want to continue to have, because I would love to see us implement something like that. Commissioner Johnson.
Yes, thank you for the presentation, and I just wanted to echo what many of my colleagues have said, that considering that you are a one-person show, this is absolutely amazing. We're up there in the top list with some heavy hitters that I'm certain have huge and large departments. So just kudos to you. Thank you for all that you're doing. We see it and we appreciate it. So
Thank you. Thank you.
Any other questions or comments from commissioners? Awesome. Thank
All
you
right.
so much for
Thank you.
sharing.
Appreciate it.
Okay, that took much longer, the two presentations, than I anticipated. So I just want to do two things, and I've cut so far into your time. I want to cover at least two things. So have committee members had an opportunity to review the minutes?
Yes, ma'am. At this time, I move to approve item 2025-1073.
Is there a second?
You'll need a second,
Oh, Lord,
ma'am.
I didn't even recognize that she had stepped away.
Yes, ma'am.
Second. All in favor?
Aye.
Okay, item 1073 has passed. Okay, and so at the top of the agenda, we are to discuss the resolution to establish a community advisory board for the DeKalb County Police Department, and this is item 2025-0390. Commissioner Terry, would you like to open this item for us?
Yes, thank you, Madam Chair. Appreciate the opportunity to speak on this. And so the resolution is before you, committee members and commissioners. We have had a discussion with, I see our DeKalb police are coming down here, a discussion previous this year that acknowledged that the Commission on Accreditation for Law Enforcement Agencies, known as CALEA, during their certification process, impanels a civilian advisory board with the cooperation of the police department to assess performance on community engagement, and as it states in the agenda, is recognized as a best practice for promoting transparency, accountability, and community trust in law enforcement. So the general idea here is that because those community advisory boards through CALEA are, one, an important part of the certification process, but are time-bound and sort of, I guess, kind of dissolve after that certification process goes away. The idea here is this would be an ongoing advisory board that would be in partnership with DeKalb County Police. The appointments, in theory, would come from commissioners and CEO. And the big vision here is just really trying to get agreement amongst the board that this is something that we want to pursue without having all of the details figured out. The last part of the resolution says, be it further resolved that DeKalb County Board of Commissioners directs the Law Department, and certainly this would be involved working with the Police Department as well, to develop the specific structure, membership criteria, and operational guidelines for the Community Advisory Board, and present this implementation plan for approval by the Board of Commissioners. So in a way, this is, think of this as a way to say we'd like to do this, but we don't have to figure out all the details and keep this on the agenda, for months and months, that we would ask the law department to work with DeKalb County Police, certainly the commissioners, to develop the specific structure, the criteria, training, operational guidelines, and then come back to the board for a final approval of what would be the actual makeup of the board. And I'll yield my time. Thank you.
Did you have any committee members have questions or comments with regards to what was expressed?
I'd actually like to hear from the police if we could.
Okay.
Thank you.
So, is this on? So, of course, this started as a different item and has evolved into an advisory board. As previously mentioned, there would need to be more information. When this originally was amended to an advisory board, we didn't really have too many details about what the intent or the role was. But it is extremely important to understand and define what that role and purpose of the advisory board would be. generally speaking, in jurisdictions where civilian boards exist and are created, whether it's a review board, advisory board, or whatever board, those boards are set in place because of egregious and serious problems that the goal of that board is to address. And in many of these places, it's really difficult to compare to DeKalb County because in DeKalb County, we love and we cherish our community and our community members very much. We consider our community a vital resource, a partner, and it shows. And quite frankly, we don't have these egregious problems where a lot of the areas that established boards, civilian boards do. So we would want to ensure that the role and the purpose of that board is clear, and that certainly more information is exchanged on that, on how it would work, how it would function. And among that, there are some other points to consider as well. Recently, in the user department assessments that were done throughout the county through the user departments, when the police services was assessed, one of the findings of that assessment team was that throughout all ranks, throughout all units of the department, it was obvious and evident that customer service was important. And as we have discussion about this, terms have been put out there about the department being accessible, being accountable, being transparent. And all of these things we have in place. Our department is extremely accessible. Anyone can walk into any precinct during daytime hours and speak with the precinct commander, can engage in conversation about the goods, the bads, complaints, concerns, recommendations. We are accessible through email, phones, in person, and we, of course, have a plethora of community events that we hold at all different times of day throughout the month, and the community participates in those. So certainly there are some things to consider, and as has mentioned before, yes, there can be a negative connotation with the board. It can represent with it mistrust to the department depending on how it is done, and we just feel that there is not representative mistrust with our community. We have a very good relationship with the community at large.
One thing I would like to share with respect to that, because I went through some of this and mentioned it to Commissioner Terry. I do like the idea of having a community board. If you look at item 1, establishment and purpose, for the purpose of engagement initiatives. So some of the things that community members bring to you at the town halls or coffee with a cop, if we had a board to make sure that we just hold the community and our officers accountable with bringing some of those things to fruition. And it's, and these are requests that they have, so if the community can play a part in helping to implement or sustain whatever those requests are, having a board to make sure we're holding ourselves accountable, I think would help, since you have those regular conversations anyway. But I did express reservations when it comes to policies and practices, because I need my board members to be well-informed and educated. However, one thing that did come to light today, which I think is very important, and I like having a data-driven approach, is that there was an assessment with M&J. I believe the police department was included. So if we could hear some of what those recommendations were, that would be important to know and have a good understanding of if those are just quick fix things or if that's something potentially the board could assist with. I don't know. I'm just kind of talking through the information that we received today, but I do think it's very important that we hear that data before making a decision, especially, just kind of wordsmithing some of this to make sure it's aligning with what our goals are specifically. Commissioner Johnson, did you want to add to that?
Yes, thank you, Madam Chair. So I think it is important that we acknowledge that if this board is established, that it is an effort to make sure that we maintain those good relationships between the police and the community that we have, and that it is not created because something egregious has happened, like you stated. And I think that a creation of the board and maintaining those strong relationships can make sure that nothing egregious happens. You know, of course, it can happen anywhere, but we want to do everything that we can to make sure that we keep those channels open, we keep those good communications going as we already have. And I think that is a good point, Madam Chair, about the scores that we heard out today, and police was one of the top ones, but they did have some recommendations. So when we delve into what those recommendations were, I think that is a great idea. Overall, I think I am supportive of this. I do think we need to make sure that we're taking our time to do it right, but I think we also need to I think it's very important for morale of our police officers that they understand that it would not be created because we think they are doing something wrong, but also more of the line of, you guys are doing a great job, let's continue that, let's build upon it, is how the approach I would like to take on it.
Commissioner Messiah.
Thank you so much, Madam Chair. And yes, I'm originally, as most people know, from New York, and came here to Georgia. And some of the larger cities, particularly those that have challenges with their police force, have boards to investigate particular issues. That is not what we are experiencing in DeKalb County. And just having a recent conversation with some of our great members of public safety, we had I was giving numbers in terms of the data and crime actually going down and being reduced, and particular crimes being reduced here in DeKalb County. So I am, and I have a great friend who's on the review board in Miami. And again, large city, have a number of challenges, and I don't personally believe that those issues are germane to what we are dealing with here in DeKalb County. I know that, you know, our officers are very involved and had the opportunity with PALS to speak to some young ladies that were actually graduating. And I mean, our officers are just very involved and engaged and approachable, even with us when it comes to having conversations related to our, you know, our concerns. So I do share a concern with having a particular board, especially where it has, well, this board per se, where it has changed so much from what it was supposed to be created for and about. And I know that I was confused earlier on because I know that Madam CEO had a task force that had been created, and I thought that that was going to essentially meet the function of what is being proposed now through this particular resolution. It was similar to you, Commissioner Bolton. When it came to Molden and Jenkins, I almost wanted to ask them, but wanted to limit my comments. Can you help us with the boards that we have going on in that review process? And that, you know, we still have a number of boards that are, we're still trying to work through to figure out what the limits of those boards are. And I know that legal has been working on it, and how many boards are defunct and what the process would be in order to eradicate, you know, those boards. And so I've just been very mindful as to creating additional ones, particularly where there's not an expressed explicit need outside of what we already have and what exists. And with that, I yield back to you, Madam Chair. Thank you.
Commissioner Patrick.
Thank you, Madam Chair. I have not heard many complaints about DeKalb County PD. If anything, I hear we don't have enough officers, and we want to see them patrolling in Embry Hills. We want to see them patrolling in Northcrest, Pleasantdale Road, Henderson Mill Road. So again, if there was a problem or a perception of a problem, I would be supportive of this, but I just have not seen a thing that would indicate that DeKalb would need something like this. And again, also referring back to the report from Malden Jenkins, y'all got a 3.5 out of 5, which means that, I guess by this assessment, you are considered a matured department within the county. So I would like to get a sidebar conversation with Jack, if that's possible, to talk about CALEA and the notion of the boards that they talk about, because I'm not familiar with that component of what CALEA offers. But again, I think DeKalb County PD has been fantastic. Thank you.
Are there any follow-up comments from commissioners? So for me, a follow-up to this would be having someone come back and speak to those recommendations for the police department to give us a broader view of the areas of improvement to see if that's something the board could potentially engage or help with, or versus if that's just, something you guys have to do explicitly internally. But it looks like you wanted to respond to that.
Certainly, we will do as you have spoken to. We'll present what we're. I think you all are not fully aware of the feedback and the activities that we do by precincts every month. And we can give you a recap of those type of activities where we receive citizens in their territory, from the majors, night out, to the patrol officers, to the community meetings. What we want to do is realize and balance that we have external customers, and that's all the citizens we serve, and we have internal customers, and we have to have a balance with that in order to recruit officers and get them to do what they need to do in a fair and equitable manner with all of our population, with lawful, legal, ethical, and that is right to do.
Yes, Commissioner Terry.
Yes, thank you, Madam Chair. So I think earlier this year, Interim Chief Pedrick, he spoke about this item, and he just talked about the CALEA process. So could you just explain, and this is the second whereas in the resolution, the Commission on Accreditation for Law Enforcement Agencies, CALEA, through its certification process, includes civilian panels to review police department performance on community engagement, which is widely recognized as a best practice for promoting transparency, accountability, and community trust in law enforcement. So why do y'all do civilian panels? Is it because you have to or because you want to?
Because we want to and we should as a CALEA. This department, if I remember correctly, since the 90s has been a CALEA accredited department. Mm-hmm. I served for over a decade as a team leader for accreditation. This department is an example of what CALEA wants in terms of community engagement, taking feedback from specific areas of the community and applying the best problem-solving mode with that, and then reporting back to the citizens.
Right. And who selects the civilian panels?
Anyone can. The panels.
I believe
we don't have a formal panel.
I believe Chief Pedrick said that the police select the civilian panels for CALEA to
to interview.
Yeah.
But they are formal panels, though, sir.
Yeah. So I guess, and this is more just my logic here. If the National Certifying Agency for Accreditation of Law Enforcement says that a civilian panel is a good idea, but they only do it at little time moments, throughout the years, I'm not sure, is it every year you get CALEA certified?
No.
Okay.
No.
How often?
It's 3 at this point.
Every 3 years. Okay, yeah. So every 3 years, a civilian panel is impaneled just for a very short period of time.
Mm-hmm.
But just so you know, we're like 5 minutes after 4, so we're going to make this exchange real quick.
Okay. Well, and that's my only point is, if CALEA believes that a civilian panel is a good thing, and y'all apparently believe it's a good thing, what is I'm trying to understand the opposition to having Commissioner, CEO appoint a permanent civilian panel that basically would do exactly the same thing that CALEA asks of the civilian panels in the accreditation process.
At this point, the way I read, and I'm not speaking for the administration per se, but the resolution of the agenda item is much broader. When you get into policy.
Did the Citizen Review Panel for CALEA act as an advisory panel?
Yeah, they heard what the assessors who come in and actually interact with and engage them, they ask certain questions of what have they observed over the time and ask about specific functional areas.
Okay.
And then they have reports to go look at. So if they ask a question about use of force, then they could actually follow through with that to see what the use of force reports actually and compare that with what the citizens thought the actual facts were.
Okay, I got you. So we'll make that the last comment because we're going to bring you guys back. But Commissioner Patrick, it's your time. So if you have something.
I was just going to say, as soon as you guys adjourn, if DCTV can be ready, I know we've already extended 35 minutes for this board and want to be able to get PWI taken care of as well. And thank you.
Okay. All right. So thank you guys. And we're just going to have you back to continue the conversation and kind of talk through some of those recommendations. So we are going to hold the remaining items in committee. At this time, can we go ahead and have a motion to adjourn?
I move to adjourn.
Oh, actually, you know what? I'm sorry. We have to make a motion on this item.
Well, are we holding it or do we need a deferral? If we hold it, we don't need a motion, is my understanding.
You got a grant? You got a grant you gotta do?
Oh, is it urgent?
It kind of is. It's just it's moving SPLOST fire station projects forward. Item 1010.
Okay. So I'm going to let you lead with making the motion for 0390. And may I have 2 minutes?
I move to defer item 0390 for 30 days.
Second. All in favor? Aye. Okay. He said 2 minutes.
Right. So the first item is the approval of usage of SPLOST 2 funds in Category A1 public safety purposes for renovation assessment of fire stations 18, 19, and 20. And I think we presented where we were going with the fire stations in the last SPLOST update, but this is trying to keep those projects moving.
Okay. What was that sum? Do we have that number?
If not to exceed 100,000.
Yes.
100,000.
Oh, okay.
They're investigating.
Okay.
Feasibility study.
This is a feasibility, an assessment. I see it. I got you. Okay. Any questions on that item? No? Okay, wonderful. Do we have a motion?
I move to approve item 2025-1010.
Second, all in favor?
Aye.
Okay, what's the next
The
one?
next item is item 1011, FY 21 and 23 Project Safe Neighborhoods PSN Community Policing Microgrant Program in the sum of $36,963. And this is to buy gun safes that we give out.
Any questions on the gun safes or the program or funding for this item?
No, ma'am.
May I have a motion?
I move to approve item 2025-1011.
All in favor? Aye. Okay. All right, so the remainder of the items now will be held in committee. Do we have a motion to adjourn?
Move to adjourn.
Second, all in favor? Aye. Thank you, sir.